Good morning everyone. I am Dr. K. Mohammed Adhil, Assistant Professor from Department of Periodontics from Incision Shankaracharya Dental College. Today I am going to present a topic on periodontal flap surgery. These are my content such as introduction, major goal and objectives of periodontal flap surgery, various type of flap surgeries and type definition, history and indication, contraindication of periodontal flap surgery, and how to diagnose and formulate a treatment plan in case of different procedures and anesthetic technique, different armamentarium used in periodontal flap surgeries. Then comes different incision type, different flap designs and post-operative complication and healing and conclusion. The goals of periodontal therapy are to preserve the natural dentition. The periodontal therapy is broadly classified as either non-surgical approach and surgical approach. The non-surgical approach include plaque control, supragingival subgingival scaling, root planning and adjunctive use of chemotherapeutic agent, whereas surgical procedures are in general use for treating periodontal disease. The fact that the disease root can be cleansed more efficiently by visual periodontal instrumentation is the reason why the surgical therapy is most successful. The major goal of periodontal therapy is to create an oral environment that is conducive to maintaining a patient dentition in a healthy, comfortable, aesthetic and functional state, and whenever it is feasible, we can do for a regeneration and preservation of a periodontal attachment. The objectives of periodontal surgery include accessibility of the instrument to the root surface, elimination of inflammation, and creation of oral environment conducive to plaque control, and regeneration of periodontal apparatus which was destroyed by the periodontal disease, and in case of improvement in the aesthetic. There are different types of periodontal surgeries like closed curettage, gingivectomy, flap surgery, mucogingival surgery, and combination of various periodontal surgical approaches. Flap surgery. A flap is defined as a loosened section of tissue separated from the surrounding tissue except at its base. A periodontal flap is defined as a section of gingiva or mucosa surgically separated from the underlying tissue to provide access and visibility to the bone and root surface. Historical background of periodontal flap surgery. Karl Platz in the year 1907 introduced Partz incision, where 1911 Robert Newman, who first introduced a mucoperiosteal flap, that is a Newman flap. Then comes Leonard Widman in the year 1916, introduced the original Widman flap. Sisonke in 1918 introduced a reversible incision. Then come Kirkland in the year 1913, introduced modified flap procedure. Then come Friedman, who introduced a apically positioned flap, and Ramjour in 1974 introduced a modified Widman flap. Limitation of scaling and root planning and other non-surgical periodontal therapy. They are limited in the areas when there is inadequate debridement in the deeper pocket, when there is a 20 to 80% of residual calculus seen in the pocket beyond 7 mm, and the furcation line angle CEJ which often shows a residual deposit, and when there is no access of regeneration in case of a non-surgical periodontal therapy, and when there is no changes in the osseous topography, in those situations we need to go for a periodontal flap surgeries. Indication of flap surgery. It is indicated when there is a presence of a persistent moderate to deep pocket even after conscientious phase 1 therapy, and presence of osseous defect and presence of inflammation and disease activity at the base of the sulcus, which are seen by bleeding and probing, and furcation involvement to regenerate periodontal tissue by the use of bone graft and membrane, and in case of gingival overgrowth and asymmetry, when there is a periodontal pocket adjacent to distal molar, and it is also indicated in other procedures such as crown lengthening and apicectomy, etc. Periodontal flap surgery is contraindicated when there is optimal result which can be obtained by non-surgical periodontal therapy itself, and when there is unprepared or uninflamed soft tissue and edematous gingival tissue, when patient is medically compromised. In those situations, periodontal surgery is contraindicated. This is how we will formulate a diagnosis and treatment plan for periodontal surgeries. When a patient reported to the department, we need to assess the chief complaint, medical and dental history, and extraoral and intraoral soft tissue. Then we need to examine the periodontal examination and assess clinical parameters such as bleeding on probing pocket depth, furcation involvement, bleeding on probing, clinical attachment loss, and gingival exudate separation. Then we need to formulate a diagnosis and prognosis of the patient, and then we need to formulate a treatment plan. On treatment plan, we need to go on a non-surgical periodontal therapy, which depends upon the severity of the periodontal disease, and need to re-evaluate after 4 to 6 weeks. After re-evaluating 4 to 6 weeks, we need to assess the control of inflammation, plaque, and either any occlusal abnormalities, in which if there is a occlusal abnormalities and there is an inflammation and more amount of plaque, then we need to move for a surgical, that is phase 2 surgical therapy. When a patient with a 5 mm pocket depth following phase 1 therapy has been reported, then we need to go for evaluate overloading plaque control. If the oral region plaque control is poor, then we need to again go for oral region instruction, non-surgical periodontal therapy. When there is a good oral region plaque control, then we need to evaluate the radiographic bone loss. When there is a radiographic bone loss greater than 80%, we need to check for the mobility, that is whether it is greater than class 2 or less than class 2. If it is greater than class 2, then we need to move for extraction. If less than class 2, we can go for a adjacent occlusal or splinting therapy. When the radiographic bone loss is lesser than 80%, we need to evaluate whether the bone loss has involved furcation or not. If it is not involved the furcation, we need to detect the type of bone defect, whether it is horizontal or vertical bone defect, and need to do the surgical procedure with or without bone grafting. And when it is involved the furcation, the treatment plan depends upon the grade of furcation, whether it is class 2 or class 1 or class 3 or class 4 furcation involvement. Surgical plans. These are three related factors which has to be considered before undergoing surgeries. First one is patient-related factor, then comes surgery-related factor, then come operator-related factor. In patient-related factor, we need to examine about the underlying systemic disease and oral region maintenance of the patient. In surgery-related factor, we need to assess the clinical parameters such as persistent probing pocket depth, width of attached gingiva, and number of teeth which has been involved. In operator-related factor, efficiency of the operator has to be evaluated. Anesthetic technique, long-acting bupivacaine has been preferred because it will minimize the repeated injection, and it has a potency 4 times greater than of lidocaine and less toxicity than lidocaine. This is the most commonly used periodontal surgical instrument such as diagnostic instrument. Then comes a BP handle, that is round body. Then surgical scalpel like number 11, number 12, number 12D, 15 and 15C, which are most commonly used in periodontal surgicals. And then periost elevator, Goldman and Glickman Fox. Goldman Fox or Glickman elevator are most commonly used. Then comes a curette like Gracie curette, universal curette. Then excisional, incisional knife like Orban and Kirkland knife. Then bone files for reshaping the alveolar bone like Sluger and Sugarman bone files are most commonly used. Then scissors and needle holder, Mayaga needle holder. The most commonly used suture needle is reverse cutting needle has to be used in periodontal flap surgery to prevent tear of the periodontal flaps. These are different type of incision most commonly used in periodontal flap surgery such as external bevel or gingivectomy incision. Then comes horizontal incision, which is classified as internal bevel, crevicular or interdental incision, then vertical or oblique releasing incision. External bevel or gingivectomy incision. This is also called as gingivectomy incision because in this picture we can see the dotted line is said to be incision line where the incision has to be placed from the apical aspect to the coronal direction. So it has to be placed on the outside of the gingiva, so it is also called to be external, so it is said to be external bevel or gingivectomy incision. It is indicated in case of gingival enlargement or gingival overgrowth or in case of elimination of the pocket. Horizontal incision. It is classified as internal bevel, crevicular or interdental incision, internal bevel incision. It is also called as reverse bevel incision because the bevel is reversed in direction of gingivectomy incision. In this picture we can see this the line is said to be incision line where the scalpel is inserted from the coronal direction to the apical direction, where in case of external bevel incision the scalpel is inserted from the apical direction to the coronal direction. So this is said to be an internal bevel incision. The most commonly used blade are number 11 and number 15 surgical scalpels. The main objective of internal bevel incision is to remove pocket lining and eliminate the pocket part of the gingival margin and to conserve the relatively less involved outer surface of gingiva. It is indicated when there is a primary incision of flap surgery if there is a sufficient band of attached gingiva and decided to correct bone morphology in case of thick gingiva. These are different types of incision for internal bevel flaps like from gingival margin. For modified widman flap, 1 to 2 mm has to be placed from gingival margin. In case of apically displaced flap, 0.5 to 1 mm from gingival margin, the internal bevel incision has to be placed. In case of undisplaced flap, the incision has to be placed from the base of the pocket. Sulcular or crevicular incision. If it is selected, if the preservation of all existing keratinized tissue is desirable. The technique of this flap is in this picture we can see this line is said to be an incision line where the scalpel is directed into the sulcus or crevice of the tooth, which is directed along the long axis of the tooth and is directed along the alveolar bone crust. And it has to be involved in including all the papilla as much as possible. It is indicated in case of narrow band of attached gingiva, in thin gingiva or shallow periodontal pocket. Interdental incision. After first two incision has been placed, interdental incision is being placed to remove the gingival collar. Orban knife is most commonly used. Then come vertical releasing incision. They are normally perpendicular to the gingival margin and placed in the line angles of the teeth and it has to be extended till the mucogingival junction. The advantage is to increase access to the alveolar bone and decrease tension on retracted flap. The incision should be placed in the line angles of the tooth and should not be included in the center of interdental papilla or at a radicular surface. Flap design. It is classified as based on the bone exposure after flap reflection, mucoperiosteal or full thickness flap, partial thickness or mucosal flap or combination flap. Based on the placement of flap after surgery, it is classified as apically displaced flap or undisplaced flap, where it is displaced flap is classified as apically displaced, coronally displaced or laterally displaced, whereas based on the management of papilla, it is classified as conventional flap or papilla preservation flap. Full thickness flap. In this all the soft tissue including periosteum is reflected to expose the underlying bone. The main advantage of full thickness flap to improve visibility of the alveolar bone and less bleeding and post-operative pain. Partial or split thickness flap. In this, only the epithelium and layer of underlying connective tissue are included, whereas the periosteum remain intact in the bone. This type of partial or split thickness flap is indicated in mucogingival surgery or when there is apically repositioned flap. Combination flap. A usual variation of these two flap is a combination flap. That is, first we need to place a split thickness flap, then full thickness, then split thickness flap. This type of combination flap are used in case of root coverage procedure. Then there are various flap designs like modified widman flap, modified flap operation, that is Kirkland flap, then apically positioned flap, palatal flap, distal molar surgery, papilla preservation flap, modified as modified papilla preservation and simplified papilla preservation flap. Modified widman flap. This flap was originally given by the Leonard Widman in the year 1931, in which Ramjod and Nichol 1974 modified the original Widman flap as a modified Widman flap. It is also called as access flap, which is used to access for the underlying bone and root surfaces. The indication of modified Widman flap is whenever reattachment with a minimal gingival recession is desired and especially effective and with pocket depth of 5 to 7 mm and with moderate furcation involvement, and it is contraindicated when there is very thin and narrow band of attached gingiva. This is a clinical technique in which the first incision is said to be internal bone incision, which has to be placed from the 0.5 to 1 mm away from the gingival margin, where you can see in this picture. And the step 2 is the gingiva is reflected with a periosteal elevator. Then step 3, a clavicular incision is made from the bottom of the pocket to the bone. In step 4, the third incision is said to be interdental incision, which is placed coronal to the bone with a curette or an interproximal knife, and the gingival collar is to be removed. Then tissue tags and granulation tissue are removed with a curette, after which adaptation of tissue with a suture. The main advantage of the modified Widman flap is to root cleaning with direct division and tissue friendly and reparative with healing by primary intention. The disadvantage is unfavorable proximal architecture immediately following surgery, and pockets are not completely eliminated. Modified flap or Kirkland flap procedure. It was introduced by Kirkland in the year 1931. These are the clinical steps. First, we have to place a circular incision which has to include both buccal and lingual surface. Then after which periosteal elevator is used to reflect the flap. Then tissue tags, a granulation tissue removed with help of the curette. Then flap has to be approximated with help of the suture. The main advantage of the modified flap or Kirkland flap is less extensive procedure and less post-operative pain or swelling, and no apical displacement of gingival margin appear. Apically positioned flap. Apically positioned flap is indicated to eliminate the periodontal pocket and to increase the width of attached gingiva and to lengthen the clinical crown for prosthetic treatment. This is the clinical step. First, we need to place a internal bevel incision followed by vertical incision, where you can see in this picture both vertical incision along with internal bevel incision has been placed, after which the flap has to be reflected with the periosteal elevator and gingival collar has been removed with help of the curette. Then comes, if needed, we can go for a osseous reconstruction with help of a round burr. Then the flap has to be approximated apically at the level of the bone contouring, then suture has to be placed. Then comes palatal flap. The palatal tissue is all attached to cartilage tissue and has none of the elastic property, so it cannot be placed apically, laterally or coronally. Therefore, the palatal tissue cannot be placed apically and a partial thickness flap cannot be accomplished. Two methods for eliminating palatal pocket, like one incision is an internal bevel incision and the other procedure uses a gingivectomy incision, which is followed by an internal bevel incision. This is a clinical technique in which first we need to place a internal bevel incision, where we can see in this picture, followed by a clavicular incision. Then the flap has to be reflected and the thinning incision has to be done. Then the flap has to be approximated with help of the sutures. Distal molar surgery. The procedure for this purpose was given by the Robinson and Braden and modified by several by other investigation. The objective of a wedge procedure include elimination of a periodontal pocket and maintain and preserve attached gingiva, make area accessible to the instrument and lengthen the clinical crown. For maxillary molars, the incision has to be placed parallel incision distal to the maxillary second molar, where you can see in this picture two parallel incision has been placed. then after which the flap has to be reflected, then pocket has to be eliminated, then suture has to be placed. In case of mandibular molar, the triangular shaped incision has to be placed distal side of a mandibular second molar, after which the incision depends upon the greater width of attached gingiva. Then come papilla preservation flap. Periodontal flap surgery with conventional incision may lead to the gingival recession and loss of interdental papilla. To overcome this procedure, papilla preservation flap has been introduced. This was given by Cottelini et al. And Taki et al., in which the clinical technique includes the circular intracircular incision which has to be placed in the palatal aspect of the tooth, which has to be followed the line angles of the tooth, after which the flap has to be reflected buccally, where you can see in this picture. Then granulation tissue or tissue tags are removed with the help of the curette, after which the flap again placed approximate in the palatal aspect of the tooth, where we can see in this picture. Then modified papilla preservation in 1995, in which buccal incision has to be given first, then after which the palatal flap has to be raised palatally, then defect has to be debrided with the curette, then if needed bone graft has to place, then vertical mattress suture. Then this is a post-operative picture where we can see there is no recession and there is no inflammation. Simplified papilla preservation. To overcome the technical problem encountered with the modified papilla preservation, simplified papilla preservation has been introduced. In this, oblique incision in papilla begins at the gingival margins of line angle, a blade parallel to the long axis of the tooth and reaches the midpoint of the distal surface adjacent tooth below the contact point. After which, circular incision has to be placed for buccal flap elevation, where you can see in this picture the circular incision. After then buccal flap has been elevated, then palatal flap reflection, then we can go for tissue tags and granulation tissue as removed, then we can place suture for approximation. Minimally invasive surgical technique. This is a term that describes the application of very precise and delicate surgical procedure that require the use of magnifying devices and microsurgical instrument and material. The minimally invasive surgical technique involves the elevation of very short and buccal and lingual flap that includes the defect associated with the interdental papilla. Two different minimally invasive technique has been proposed. The first procedure that includes the elevation of tiny buccal flap as well as the elevation of the interdental papilla and the palatal flap, and the other technique which involves only the elevation of the buccal flap. These are the procedures for minimally invasive surgical technique. The post complications of periodontal flap surgery, such as post-operative complications which include pain, swelling, bleeding, reaction to medication and infection, and other potential risk factors include root sensitivity, flap perforation, abscess formation, and irregular gingival contour. And delayed complication can be delayed healing, hemorrhage, mobility, periodontal abscess, and infection. Healing after periodontal flap surgery. Within minutes, there will be a blood clot which occupies the flap and the bone. Then within 2 days, there will be influx of fibroblasts and budding capillaries which may initiate the phase of granulation tissue formation. And in 4 days, there will be granulation tissue formation visualized at the dentogingival interface. And 7 to 10 days, the flap has to be approximated and there will be less interposed reparative tissue and lesser amount of clot has to be resorbed. In 2 weeks, there will be collagen fiber has been appeared to assume a pattern with consistent with that can be seen normally. In 3 weeks, thick and regenerative connective tissue cover the crest of the bone. And 4 to 5 weeks, maturation repair of all the tissues involved. And after 2 to 3 months, flap firmly reattached to the tooth via dense organized connective tissue and cementum. So here I concluded that every surgical procedure must have an endpoint before the initiation of treatment. With the current emphasis of evidence-based periodontal therapy, scientific knowledge, when available, should become the primary driving force in therapeutic and surgical decision making. Clinical judgment, personal experience, and patient preference are still available entities in decision making process, but they may be integrated with the sound science to improve the predictability, quality, and efficiency of periodontal care. Thank you for listening.